Okay, so thanks everybody for coming. It's my pleasure actually to introduce Dr. Madjid Soltani. He's actually a former UW alumni from, he got his PhD here with Professor Puchen, exactly, Professor Puchen. And his research expertise is in transport phenomena in biological systems with a focus on a nanoparticle drug delivery to the solid tumor microenvironment. So after he finished his PhD at Waterloo, he was in the US at Johns Hopkins, and then he started as a professor in Iran at KN2C University. And he's published quite prolifically in journals and conferences, and he's actually the director of the Computational Medical Institute at the KN2C University of Technology and the Ministry of Health in Iran. And he's going to talk to us today about a form of predictive medical imaging, if I understand it correctly. It's image-based models of solid tumors, behavior and diagnosis, treatment, and prediction. So without further ado, welcome.
Okay, thank you. Okay, good afternoon, everybody. It's my pleasure to come back after almost 3 years to Waterloo. I think it's better to stand this way. And special thanks to Karim for inviting me, and also Christina that set up everything. And thank you for all coming. I know it's almost late afternoon. Hope we will get something to the prediction as is interested of Karim. I have two presentations. One is a little bit longer to see why we need to go to the predictive modeling, and short at the end, but hopefully we will meet both of them. And maybe we have to go faster in a few slides, but feel free to ask any question about any of them. And by the way, all of them, she did a great job and put a link to my LinkedIn, I think, in the poster. Therefore, all of the document is online and open in open access journals, and therefore there's no, even for codes, if you need anything, just you can contact me. The outline, I try to summarize a little bit about cancer, solid tumors, drug delivery, barriers, which is directed to kind of my area, which is transport phenomena. And most of the people believe that this is the main kind of barrier in drug delivery in terms of engineering side, not from the medical side. Because from the medical side, if you talk to any doctor, they try to do something right in the dish or in the cell culture. But when it comes to the engineering side, we see some drugs are effective even 95% in the biolab, wet lab. But when you do in vivo test, the efficacy and efficiency is less than 5%. We are looking for that problem. What's the main problem? And for that one, we need to use modeling. Mathematical modeling is the easiest way and kind of economic way to look at these problems versus real tumors. This is the introduction, and then move to the mathematical modeling. In the mathematical modeling, I'm not interested to talk about kind of this, and maybe you are not interested as well, but we have to do that, because without knowing anything about the velocity of the interstitial fluid and blood flow, and also from the effect of size and shape of the tumor, and also the second phase of the tumors, we cannot go further to the last one, which is image-based modeling. Therefore, we need to go from these steps and talk about a little bit about the angiogenesis, capillary network, and then move on to the image-based modeling. And at the end, I try to summarize my talk and also talk about future plan of our study. You know that it's controversial that cancer is first, or depends on the society you are talking about. But in North America, we know that the statistical is not that much good, because we see that in 2015, I don't have any update, 180,000 new cases of cancer, and also close to 80,000 deaths from cancer in Canada. It was the Society of Cancer in Canada. They announced this. And also, if we talk a little bit about the bigger society in the North America, we know in every fourth, one of them is related to the cancer. And from our perspective, which is very important, 85% of the cancer related somehow to the solid tumors. Therefore, it's a big area of the research for the people who are interested to the cancer. This part is the major part, actually. Besides this, you have melanoma or kind of blood cancer or those things which is not related to the, but it still is a cancer, as you know. Okay. What is the main barriers when we talk about drug delivery? The main important obstacles or barriers are clearance of drug. For example, if you do bolus injection or systematic injection, you will see after one blood circulation, part of the drug is go to the, for example, renal system or kidney. Therefore, this is very important. And when we do wet experiments, we cannot look at this part of the drug, kind of clearance. The second one, which is very important, and you can find most of the top journals like Control Release talk about the second one, which is resistance of the tumor cell. And it's very important if you look at some specific cancer and do chemotherapy, for example, or radiotherapy, and the dose is not correct, this happens. And it's very, common in most of the cancers, resistance of the tumor cells. And that means you have to do the next try a little bit higher dose or a little bit higher radiation, and this has side effects, as you know. But which is related to this research and comes to the third barrier is physiological barriers. And by the way, from engineering perspective, this is very important to the concept that we look at from the engineering perspective, physiological barriers. I try to talk about this in the next slide in a better way. This is a very simple model of the solid tumor. We try to put everything in the this schematic, and I try to put the links and also the address if you are interested, but as I mentioned before, if I forget to put the name of the papers, you can find them easily. This is a cross-sectional view of a three-dimensional solid tumor. At the center, as you know, we have necrotic center. It means some people call that avascular part. It means there is no oxygen and therefore no blood vessels. And some people say, okay, if this is the dead part, why do we need to take care about this? And this comes to the next slides. You will see the main problem comes from here. And the second area or second kind of layer, which is the semi-necrotic region, we have a little bit of the vasculature distribution. And in the proliferative area, we have a kind of well-vascularized region. If we are doing the systematic or even bolus injection, this is the way to have drug delivered to the right places. But what's happened from the governing equation or from the engineering perspective? If you see these two arrows, the black one, it says outward convection due to pressure gradient. In the model, we showed that. And if you look at the detail, you will see how we can calculate that. If we have change of pressure inside any part of the tissue, by pressure I mean interstitial pressure, that's a symptom or kind of clue that something is wrong with that part of the tissue. And we showed this in our research. Therefore, we have gradient of the pressure from the center to the periphery area. And if we are interested to have drug and send them or deliver to the center of the tumor, we need to have more drug here and naturally less drug here. Therefore, we have gradient concentration of the drug. If we are going to have a successful drug delivery, this kind of force should be greater than this one. And most of the time, this is not the case. Therefore, even if you inject even drug to the center of the tumor, by the bypass of and the effect of this gradient pressure, drug leaves the tumor immediately. And most of the time, this happens. And because of the pressure, we try to show this, what's happened here. Even if there is any vessel or microvessel here, because of too much pressure around the vessel, doesn't allow too much drug comes to the tumor. This is the main problem that I think the first people addressed this issue was a Still lab in Harvard in late 90, Professor Rakesh Jain, and he has almost every year a course called Tumor Physiology. And they addressed this issue, but they didn't go further at that time for the modeling. Just they tried to develop an analytical solution for this problem. But we use, based on the tools that we have these days and computational effort, we use for any shape, as you will see in the next slides. And also, by the way, this is the real solution. And if you look at the legend here, you will see the pressure at the center of the tumor in the maximum level, which is dimensionless pressure, which is around 1. It means we have almost the maximum pressure at the center of the tumor. Therefore, if you put anything even here by forced convection or by injection, it goes to the periphery area immediately. Okay. Doesn't go further. Okay. Yeah. By looking at that kind of schematic, we try to find out what's the best way to model something like this. This is the real tumor with the microenvironment and microvessels. If we go with a very simple model, as I mentioned, we need to separate 3 different zones and also heterogeneous distribution of the vessels. No vessel in the necrotic zone, a few vessel or low distribution of the vessel in the semi-necrotic region, and high kind of distribution or well organized of the vascularized of the vessel in the periphery area. But still, this is very complicated model in terms of computational work. And this is just in 2D. If you look at this in 3D, it's almost huge kind of computational work. We go further to use the simplified model. In this case, we assume that we have uniform distribution of the vessels. But what is the size of the vessels, microenvironment? Almost 5 to 10, or in some cases, 20 microns. And what is the size of the tumor? Around 1 centimeter. Simple calculation shows that we have kind of multi-scale problem. If you are going to have this problem and solve it numerically, you have 4 order of magnitude difference between these two. And even for simple case like this, it takes days and weeks to solve this problem. Look at the drug, nanoparticle, and the movement of the drug inside the tissue. Therefore, we use kind of simple math for that. Instead of having vessel in a point source, we use continuous distribution of the function of the blood, which brings inside the tumor the oxygen, nutrition, and also the drug. And with the background of any engineering courses like fluid mechanics, you know that the simplest case for tissue is pros media. And if we use the governing equation for pros media and also the continuity equation for the vessels, we end up with this simple equation, Laplace or Poisson equation. And again, everything we try to solve this. The detail is here if you are interested to know. The main problem here is that how we can calculate the pressure as an indicator of the tissue property or tumor tissue properties. And this comes from the medicine. One doctor in, I think, 150 years ago developed an experimental relation for this as a source term called Starling's equation. For any part of the body, if you are interested to know what is the difference, what is the source coming by blood, you have to look at the pressure inside the vessels and also environment of the tissue, and you can simply calculate it, what is the rate of any source coming to that part of the body. It's called Starling's equation. We don't want to talk much about the detail of that. And this is the Starling's equation, by the way, developed first by this doctor, as I mentioned, 150 years ago. Therefore, we can simply calculate what is the rate and exchange rate between blood vessels and the tissue around that. This is the solution of the Steele group and Jain, as I mentioned, Rakesh Jain, 1990, and also they have a cancer research paper and also a Nature paper in 2007 about this. This solution is based on the analytical solution, and they can use this just for a spherical tumor. But we know that a spherical tumor is not the case most of the time. First, we try to validate our numerical approach and solve our problem for them, for their case. And this is our result. And after validation, we were sure that our method, which was the numerical method, is okay for going forward for any further cases like, I don't know, any cases that comes from the imaging side, not just the simple cases. Then we moved further to find out if, instead of just having the spherical solid tumors, if we move to oblate, which is this guy, and also the prolate, is there any difference? And this is a very important point for people who look at the imaging. If you talk to some doctors about the different shapes, they just look at the volume of the tumor. And before these results, if somebody asks me, is there any difference between this volume of the tumor, based on the literature, I had to say no. But look at the 2 or 3 difference order of, difference between the flags and the, by the way, drug release at the center of this tumor and this one. And the main outcome of this, which was published in Journal of Biological Engineering, was that in this case, as you see here, is very close to the spherical solid tumors. But for the oblate, and this is the simple maybe rules of the electrical engineering or fluid mechanics course, if you have some way for drug to bypass, it happens simply. Therefore, the main outcome here was that just looking at the volume of the tumor and do some treatment for different shape is not the case always. And this is maybe first clue to go toward the personalized medicine. And also in the next figures, we show that if we change the size of the tumor from 1 millimeter to 1 centimeter, almost here we have again 2 order of magnitude difference between the flux or the drug at the center of the tumor. But this is very maybe trivial statement for the physician. If you go to doctor and say that we find out a tumor in the size of 1 millimeter and another tumor in the size of 1 centimeter, what is the chance to have drug at the center of the bigger tumor? For sure, he said, okay, it's easier to have drug at the center of a smaller tumor, and we can deliver more drug at the center of a smaller tumor. But nobody before that showed mathematically that is true, and find out what is the reason. And one important point, maybe it's very interesting, and I remember at that time it was one of my external question. It said that all the literature says that if we have more leaky tumor, we expect to have more drug coming inside the tumor. Why this figure shows that there is an optimum value? And you know why? The reason is simple. When we are in this area, most of the people and most of the data in the literature is just related to this part. And people think that this is the case always. If we increase the leakage, this is the surface area, by the way, to the volume of the tumor, another indicator for the people who work in the imaging area, and also the leakness of the vessel wall of the tumor. It shows that if we have more leaky tumor or vasculature, the rate of the drug should increase. But it shows that there is an optimum value for that. And this is very important as well. When we find out, as I mentioned in the outline of the talk, when we look at the modeling, first we need to calculate pressure and the velocity of the blood and also drug. Then we have to calculate the concentration of the drug. For the people who work in the PET area, anybody here in this room? If you look at this figure, it just shows very close to the positron emission tomography or PET images. What is not PET? Is the synthetic images that we calculate based on the math and also the all equations that we put in the paper, not too much here. And by the way, if you look at the literature of the PET, the resolution is around 1 by 1 millimeter to 2 millimeter per area or pixel. But here, because we do all the calculation and by finite difference, finite volume, or finite element method, the pixel size that we have here is around 8 microns. Therefore, we can do any extrapolation to fit with the PET images. And when we first had a poster in the IEEE conferences, just a few experts in the PET noticed that how do you have 8 by 8 micron pixel of the PET? We don't have that in the literature. And I said, oh, this is a model. It's synthetic. It's not a real PET images. And this is another important point about what we can do based on the images. The answer is inverse problem. All we talked till now was related to the phased phase of the tumor, solid tumors. Tumors maybe to 2 millimeter in size, 3 millimeter, or 1 to 3 cube millimeter in the size and volume. What happens if there is no process like angiogenesis? The size of the tumor doesn't change anymore, even for 20 years. And maybe you have heard that some doctor says, don't do anything for this kind of benign tumor. Don't do that, anything for that. What's the reason? Because as long as there is no vessel around that and there is no way to go for the next phase, we don't have any problem. But if something happened with that necrotic part and send some signaling to the other part of the body and say, okay, I need more oxygen and more nutrition and also to transfer the waste material that we had based on the system of the body, that's the major part of starting maybe malignancy or malignant tumor. And this is related to the angiogenesis. Angiogenesis by word is a Latin word and means new vascularization. And the good point about the research again is that angiogenesis is not related just to the disease. For people who works in the heart area, heart disease area, or people look at the obesity as a main problem of these days, we can control these two diseases by method called anti-angiogenesis. It means control of not sending any nutrition, any oxygen, or any material to those parts of the body. All slides till now was related to this part, which is avascular phase. But again, if there is a cell communication and cell signaling between the center of the tumor and the closed or nearby blood vessels, it starts to have some blood circulation system, and because it's new for the body and it's not related to the normal blood circulation system of the body, they call new vascularized system or angiogenesis. And this is very dangerous because if there is any communication between these two, cancer cells can go to the blood and go to the other part, and that means metastasis or secondary solid tumor in any part of the body. And again, we need to do math in a very simple case. Like most of the people, this is a standard problem in the angiogenesis problem. They look at the 2 by 2 or any size close to this area, because we need to have, again, many calculation and many math formulation. Therefore, they try to choose the smallest domain because it's time consuming. And most of the people look at this problem in 2D, not in 3D. We have tumor. It could be linear tumor or circular tumor, and at the other part, we have closed or nearby parent vessel. What happens between tumor angiogenesis factor, extracellular matrix, and all this? It comes to the partial differential equations, ordinary differential equations, and solving sometimes 3 to 11 different equations to end up with something like this. And at that geometry, by the wait time equal to 1 means 1.5 days. Here we are at the 3rd day of our experiment. Here we are at the 6th day of experiment. And if we do this experiment in any animal like mouse cornea, or rabbit, we will see exactly the same pattern. And here we have tumor, and here nearby. And it shows that how the new vascular system happens in this part of the tissue, which is the abnormal tissue or tumor tissue. And solving this problem again, we have to look at 3 different scales in terms of spatiotemporal. For temporal, we have to look at this because if some of you have done any experimental, you know that having a tumor in a rabbit eye or mice takes around 18 to 20 to 25 days. Therefore, the time scale for that tumor growth is around 2 or 3 weeks. But for a spatial resolution, we have to look at tissue level, which is around 1 centimeter or a few centimeter. If we look at the vasculature of the tumor, both venous and arterial side, we have to look at micron. And if we look at the cell communication, we have to look at the molecular scale. Therefore, for solving this problem mathematically, we have to have, in our calculation, we have to have this. Otherwise, you can look at this just in a simple model. But if you want to have any connection between different scales and solve the problem comprehensively, you have to look at different scales. Again, it shows the detail of the model. This is the domain. And because of the symmetry, we can save computational effort and solve the half of the problem. This is just the simple outcome of the model. But if you show this to any physician or medical side, they don't accept this because we don't have any, dead end vessel inside the body. We should have a kind of loop in our system because we don't have anything like that inside the body. What's the solution? We call geometrical pruning. Therefore, we have to get rid of those dead-ended parts. The result is a green one. And we have to solve all the blood flow inside this green. And this comes to the red one. Red one means if we solve in the green one, in some places, the velocity of the blood is 0. Is it possible inside the body to have blood velocity? Therefore, physically, it means we end up with this. And now, if you are looking at the drug delivery problem, in terms of mathematical modeling, we have to use the red one. And this is the calculation of the pressure inside the specific part of the tissue. Again, you see we have almost maximum value of the pressure close to the parent vessel. Here is a comparison of the result in the previous model. As I mentioned before, here we assume that we don't have any vessel. But here we see if we have any network or capillary or microenvironment, what's the effect of these two. And if you look at the numbers, even the numbers almost is doubled. Therefore, it shows that looking at the solid tumors without the effect of the network or microenvironment and angiogenesis, it may, results in a big mistake, almost 100% error for that part. And this is just a 3D value of the pressure. And this is just how we can show all these steps. Okay, the animation doesn't work. We try to just show how all the steps works in our coding or in our software. We can go further, as I mentioned, in the molecular scale to see what's happened inside the angiogenesis process. And by this one, we had to look at the molecular or intracellular scale very deeply. And just this part, if you want to imagine how much work you need to do, just this circle was the work of one of my PhD students. And the result was interesting, as you will see in next slides. And we showed that here. Not just looking at the blood flow is important, but looking at cell communication between different molecules inside the cell is vital part of the modeling. Otherwise, you missed some important result. And this was just published in 2015, and it was the first report that showed we need a specific value of blood vessels to have cancer or solid tumor continue to its growth. Otherwise, it collapses. And all the reviewer mentioned this is very good point or direction for the research, but we are not sure because nobody has done any experiment for this yet. This is, again, we need to do simple calculation, but because we looked at the detail of the modeling, even this extracellular matrix, we spend a lot of time to make something close to the real tissue. For the people who works in the tissue engineering, they know that how important is making extracellular matrix close to what we have in the real tissue. And also, again, because this is in the molecular scale, we cannot use simple partial differential equations or ODE. We used Monte Carlo simulation for this one and a statistical. And right now we are doing kind of molecular dynamic modeling to see how we can find out more detail about the angiogenesis process, which most researchers believe that this is next maybe 10 to 15 years is the decade for angiogenesis research. Again, we need to make very strong connection between these three scales. For example, in the tissue or organ level, we have the size and time, and also some important phenomena like branching. When parent vessel have communication with the tumor or with the cancerous tissue, they have to make some connection. And after certain time, you will see just one vessel cannot go by itself. It needs to have branches. And what happens if two branches come together? Again, Latin word for that is anastomosis or fusion. And nobody had looked at the fusion yet in terms of modeling. If you are interested in modeling, and this is the basic part of any molecular or agent-based modeling, we have to look at any cell with the arbitrary shape like this. We have to look at the fluid. We have to look at the normal cells. We have to look at any entity that you are interested to have inside your agent domain or in lattice site. But this is just one tumor cells, and we are interested to see what's happened to this. It's a simple message of this modeling. This was what I talked about. If two vessels come together, this process called fusion or anastomosis, and this is branching. Two groups worked on the branching beside our group, but nobody looked at this yet. How we can model fusion of the vasculature. And this is the output of the model. And this takes, just this simple loop takes around 2 weeks of the computational work. What we've done, and it was new in this step, is two next slides. This one, we showed that if you don't have any blood flow inside the new vessels, it cannot be stable anymore. But what happens if we solve blood flow in the vasculature and neovasculatures? This is the next slide. And we introduce inside the +1 paper 2015 what is the main criteria for kind of blood flow or stress fluid for this step. And if you go further that critical value, you have a stable angiogenesis. It means you have next phase of the tumor or cancer, which is the metastatic stage. If not, there is no tumor growth anymore. Because I want to talk a few minutes about the image-based modeling that we are doing right now, I just want to share one of our study at the Johns Hopkins, because we showed that mathematically what is the case for the effect of shape and size. We had 100 cases of pancreatic tumors, and we used the same terminology. Before that, it was not possible because, for example, if you are going to solve analytical solution for shape like this, it's almost impossible. Therefore, we used our code and our methodology to show that is it any big difference between different size and different shape in next two slides. And this is the related to our detailed calculation. And we used to show what is the aspect ratio for different tumors. The main reason for that is, as I mentioned, people just right now, if you go to any doctor for this problem, they just look at the volume of the tumor. All we are going to do is show that the aspect ratio and the effect of the shape is very important, at least for treatment and diagnosis and prediction. And this, again, for those cases, we try to find out between, and you know that it's very complicated to look at different experimental images or from clinical images to find out what you are looking for. And between 100 and a few more than 100 actually, we find out these 5 different shapes. And this is the detail of our calculation. And this is the difference. Maybe you say this is not huge, but if you ask the clinical people right now, they say it's not any difference. It should not be any difference. But this shows there is something we have to look at that carefully. And also, for some cases, we showed that it's not important to have different shape. Why this is the case? Because if you are doing some calculation like that, you have to look at which drug. If you look at anti-angiogenesis drug, if you look at monoclonal antibody, if you look at other, tracer or drug, it's very important. But right now, these things is not important at all because all they look at is anatomical images and see which is right, which is wrong. But combination of the anatomical and clinical and functional imaging shows right now there is a big difference between the effect of any characteristic like those I mentioned. And again, we showed that even for different, we looked at 2 tracers, FDG and F-MISO. Those 2 tracers, radio tracers, are just 2 of 100 tracers that these days use in the nuclear medicine. And we find out for these 2 different F-MISO and FDG, there is a big difference to show what doctors looking for. Therefore, we need to go for the modeling because we don't have that much time to do all of these things just in the clinic and or animal study, both for the cost and for the time. We don't have that much time. If we have glioblastoma, we have just around 6 to 15 months for the patient. Therefore, we cannot do all of these things in animal study or in the clinical study. Again, if you look at this and show this to the PET specialist, it's very hard to distinguish which one of those are from the mathematical modeling and which one is coming from the hospital. And the detail of the calculation, the only things that it's important to mention here is talking about the inverse problem that I mentioned. Why is important? I remember when I had a talk in Nuclear Medicine Society last summer, one of them asked me, are you looking for, canceling the PET in the hospitals? I said that no, that's not the case. We are looking at inverse problem. If we have these images from the PET, which is really the images from the PET, and we use inverse problem to find out the tissue property, that is a huge step in research because you cannot measure any tissue property even for animal study. Therefore, with this, we showed in our last paper how we can find out the diffusion coefficient of any drug or tracer based on the imaging from the PET or functional MRI. Before we finish the talk, I prefer to look at this slide here. This is the sample work that we have done. And beside our work, there are 2 papers, one from the NIH group at the Baltimore, and also another one from I believe it's from the group in the Yale. I'm not sure, I should check that. In sample work, sorry. In this sample work, all we have done is if we have two different modality like the one from anatomical imaging and the other one from the functional imaging, we can go to find out what is the next step of any tumor growth. And why this is important? Because we want to look at the rate of the oxygen that a specific tissue needs, what's the perfusion of the tracer or drug, and also what is the morphology of that in the next step. And imagine we have these two from the anatomical and functional imaging, and we are going to use based on the, or I think it's going backward, yeah? Because I don't want to talk about this anymore, yeah. Okay, imagine we have any of these two for this tumor. This is the brain tumor, and we have, again, need to do a lot of calculation, like intracellular volume fraction. Imagine we have those things, and by the way, this is just baseline, and we have another imaging in 2 weeks later, or at least we need to have 2 weeks, because if there is no changes between the first images and the follow-up, you cannot do any calculation to predict what is the next step. Therefore, our calculation shows that at least we need to have 2 weeks interval for the second phase, or for the second imaging or follow-up. And if we do our mathematical modeling, the outcome is the predicted tumor growth. And for sure, we need to check that one with the real images if it's possible. And sometimes it's not easy to set up everything, because most of the patients are not happy to have 2 weeks later after the first baseline. And we don't know what we can do right now. The one solution is looking at animal study. But for the human study, the only cases that people are allowed, or people allowed the physician to do this, I read in the literature and I found out just 4 people in some area, I don't know where, they allowed to, without any treatment, they allowed to do imaging and see what's the tumor growth rate per time or per area of the brain. And finally, we are looking at this one right now and work at the developing and improving our software. If we have different modality of the imaging, especially from both anatomical and functional, is it possible to predict tumor growth? We have good news for this one and test for the animal study just in the nude mice. But for therapy plan, it's very complicated in terms of modeling, because at the same time, you have to model what's the tumor growth by itself, and also the effect of the radiotherapy, immunotherapy, or chemotherapy. And there is not much work in the literature at this, but it's our dream, and this is the main reason to push researchers toward the personalized medicine. And I think that's it for this one. Do we have a few minutes to come back, or to other one? If not, we can. Okay, let's finish it here. If there is any question, I can answer your questions.
We're okay on time, so let's thank our speaker. Floor is open to questions.
Okay, thank you. I'm ready to answer any question if you have.
I had a question about this predictive model that you were talking about. So,
Oh, the previous slide?
Yeah, exactly.
Okay.
Previous slide. You said it's got to be anatomical and functional. So is there a situation where, like what anatomical methods would satisfy your requirement? Does it have to be CT
No.
or?
No, it's not important. All we need from the anatomical side is the area of the lesion or the tumor, or just separate normal tissue. Exactly.
Just the area, not the body?
For the 3D modeling, we may have to look at the surface, outer surface, because based on that, you make your own model to go what's the next step in terms of, geometrical point of view.
Probably if you need volume, then CT or some kind of 3D tomosynthesis method is better, yeah, to supply the data.
But nothing I've done in 3D yet.
Not yet?
Not yet.
Oh, interesting. And for the functional side, you're thinking like PET or gamma or something like that? Or
Functional imaging, functional MRI,
yeah.
functional MRS,
Okay.
and PET or SPEC.
So is there one technique that's better suited for this type of modeling than another? Like you said?
Depends what are you looking for. If you look at, for example, chemistry of the drug, and you are interested to know what's, for example, for the specific drug, the binding rate, you need to have the special resolution. Therefore, the functional imaging techniques should be good in terms of a special resolution. But for general, just idea of tumor prediction is not important.
It's not important.
No, but
you could go for the least expensive method and
exactly.
get the same accuracy.
Yeah. But I know most, for example, pharmaceutical companies are interested to know what's the diffusion rate of that specific biochemistry, material. For them, the resolution and finding because if you don't have that much resolution, you missed some phenomena at that scale. But for physicians and oncologists, they are just interested to know, and it's very great if they know if you do this dose of chemotherapy or radiation, what's the consequence?
Yeah,
that's all they need. Depends on what we are looking at and what's your inverse problem. Exactly. If the inverse problem is finding the geometry, we can go with the simplest model, and it's huge, by the way, especially in 3D. I know that many specific groups in at least 2 or 3 centers in the US looking for this problem. And by the way, the problem is that much difficult. They just look at the GBM right now. Because as you know, for GBM, there is a limitation of space. Therefore, finding and prediction is much easier than lung cancer, because for the lung, there is no limitation and we can not maybe predict that easily. It's the very, very first step of this research, I believe.
I don't want to monopolize. Anybody else who wants to ask? I like the
question. So you mentioned earlier on that the pressure gradient from the inside of the tumor to the outside of the tumor is a big problem for drug delivery. What is it that causes that higher pressure inside?
Good question. Any idea? What is the main problem of having build-up pressure inside the solid tumors? Well, sorry for didn't mention that.
Not why is it a problem, but why does that happen? Why is it that there is that pressure gradient from the inside to the outside?
Yeah. If you look at our body, we have 2 important systems. One is the blood system, and the other one is lymphatic system. And till now, there is no literature shows that for cancerous tissue, we have lymphatic system or we have lymphogenesis. Just one group, I heard that in 2016, I believe in EPFL, they announced that there for some tumors and for some tissue, we have lymphogenesis, like angiogenesis. But imagine that we have kind of place here, and air or water comes in, but there is no exit from that. What happens? Just build up of the pressure. And that's the main problem for at least most tumors solid tumors. We have just input. There is no output.
So it's the blood vessels that are I guess, putting in fluid into the tumors, but there's no lymphatic system
Yes.
to remove it.
We have all source coming in, no sink coming out.
Okay, interesting. Are there any organs in the body that have that? Like, I don't know, your liver?
For sure, for the brain, we don't have any lymphatic system. Therefore, because of that, it's very, very, almost impossible to treat brain because we don't have any lymphatic system. And because of the blood-brain barrier, you cannot sending in anything. And most people like Langer group try to do kind of, putting chips for drug release. It's because of that. But as long as we don't have anything as an exit of that system, it's very, very difficult to do and send more inside because already it's built up, and it's full. Therefore, people may look at that by microfluidic or something to make some, it's idea to make something as a synthetic, lymphatic lymphogenesis system or some idea, just people talk about that. But for sure, for brain, we don't have any. For pancreatic, the work shows that there is no lymphogenesis. But I said that I can send you the link for the Cancer Society of the EPFL group. And by the way, she worked with Professor Jane group in the Harvard. She was his former student's PhD, and she announced that and she published in the Nature. We have lymphogenesis for some organs, not for all.
Very interesting. Thank you.
No problem. Thanks.
No, in that case, let's thank our speaker again.